G'day, I'm Alan Giles, an emergency physician. Welcome to the next in a group of case studies that illustrate the effects of electrolyte abnormalities in patients that present to the emergency department and what some of the treatments are. In this particular case, we're going to do a PowerPoint presentation, and then I'm going to use a video from osmosis.org to illustrate, in this case, SIADH, which I think would be certainly worthwhile going through again. What I'll do is just start with the PowerPoint slide. And this particular patient is called How Low Can You Go? So it's an elderly patient who's 85 years old. He's been treated by the local doctor for a urinary tract infection, an E. coli urinary tract infection with some Keflex. And she's been well. I mean, she's got a background, you can see she's on some carbazole, she's got hypertension. Interestingly, she's got an adeno-CA of the colon, but she's had urinary tract infections before, and this is another one. We've been treated with Keflex. She was well this morning, but this afternoon, it looks like quite unwell, unsteady on her feet, getting confused, and they're not too sure whether she's septic or whether maybe she's having a stroke, so they refer her to the ED. The first entry on the ED notes is actually by the staff specialist, and it's done retrospectively because she immediately, whilst waiting for a doctor, has a seizure, a generalized seizure, and it lasts for about 45 seconds. In terms of the quick additional history that's gained, the only additional part really relevant is that, potentially relevant, is that she's did have this history of heavy alcohol dependency. And there was no focal weakness or facial droop linked to this to be considered that it actually was a CVA. The generalized seizure stopped. She was incontinent, she bit her tongue, and her blood sugar was normal. She was a little bit hypertensive, and the heart rate was about 90 per minute. They didn't have to give any benzodiazepines to her. Okay, so a generalized seizure, uncertain the cause. She's afebrile. They take a bedside gas and some electrolytes, and it shows she's got a mild to moderate acidosis, which is here. It's metabolic in origin, and there hasn't been any compensation, and this would be not too surprising following a seizure. However, when they took some electrolytes, they found this sodium of 108 certainly might be the cause of a seizure and confusion, with a commensurate elevation in, or commensurate an elevation in potassium of 6.2. Part of it will be because of shifting with the acidosis across the cell membrane. Also, she has an elevated creatinine at 158, and previously it was about 110. So the question is what to do. We don't really know the cause of it, so we should probably take some serum and urine sodium and osmolality. But do we treat her with 3% saline, 0.9% saline? So they thought, well, okay, we think it's a seizure due to hyponatremia. We can't find too much else on examination. We've sent away some bloods and some urine and serum osmolalities and sodium. They called the on-call physician, who said, well, let's give 150 mils of 3% saline, so hypertonic saline, and go to ICU. Apart from elevated prolonged QT, the ECG is unremarkable. They speak to ICU, who said, look, I prefer not to give that. Let's just give some 100 mils an hour of normal saline and repeat it in 2 hours, the sodium. Unfortunately, we don't have a bed. Well, not at the moment. And after a couple of hours, she had another seizure, which required some midazolam, and then she had another seizure, which required some more midazolam. By this stage, they said, look, let's just give her some 3% saline, so hypertonic saline, but they only gave 50 mils. And also, the problem therefore after these seizures and midazolam with the underlying hyponatremia, her GCS was getting quite low, and they wanted to intubate her, which is also hypotensive. Intensive care came down and said, well, we actually don't want to intubate her, but we can take her upstairs soon. So there's a bit of argy-bargy with intensive care, between intensive care out of hours in the emergency department. They gave her some phenytoin, and you can see here's the midazolam. It was given a couple of milligrams over the time, some arabine to prop up the blood pressure, the phenytoin, And there's the GCS, which is low. It comes back up afterwards. And there's the period of hypotension before she goes upstairs to ICU. What happens in ICU? Well, there's a little bit more history that was gained, and they drilled down about the urinary tract infection. She's been drinking a lot of water, probably 4 to 5 liters a day for the last few days. Nothing else was found on history, and they did a CT which showed moderate small bowel, nothing very much really. They then increased the amount of 3% saline in ICU and gave her a noradrenaline infusion and waited for her blood pressure and for her GCS to come up. She did. With the sodium came up to about 115, GCS came up, and they continued to rise. They noticed that both the urine and the sodium osmolality was low. She's got a little bit agitated by the time she left ICU, and then was discharged well with a GCS of 15. And the feeling was she had water intoxication as a cause of hyponatremia, seizures and hyponatremia. So it's one of the less common causes of hyponatremia we see. So I thought we'd just have a look at something which a lot of you or all of you will actually remember. We'll just go back over it again. That is, how do you classify hyponatremia? And there's apparent hyponatremia, we'll talk about first, and then there's that related to your volume status, whether you're hypovolemic, euvolemic, or hypervolemic. Let's get the apparent one out of the way. So apparent, most commonly we'll see it if you've got someone that you have to adjust the sodium in the that you see according to how high the sugar is. In this case, say someone comes in with a sodium of 115, but they've got a blood sugar of 40. So what you do is you take how far above 10 millimoles per liter the glucose is. In this case, it's 30, because total number 40. Divide that by 3, you end up with 10, and then you add that to the sodium. So if the sodium was 115, you have to add the 10, make 125. And this is the apparent one, most commonly seen, as I say, with hyperglycemia. You correct the sodium up by 1 millimole per liter for every 3 millimoles of glucose above a glucose of 10 millimoles per liter. Okay, let's go on to the more common classifications, the hypovolemic, euvolemic, and hypervolemic. So hypovolemic, obviously you've got a low volume, but you've lost more sodium than you have water. So that's why you've got low sodium and low volume. It may be caused by things just your kidneys or things extrarenal. So this is the more common way of breaking it up. The renal causes, which the renal causes indapamide, especially as a diuretic, or salt-losing nephropathies, adrenal corticodeficiencies, or renal tubular acidosis. They're the ones which I remember for a renal cause. More commonly, certainly worldwide, would be the extrarenal causes, especially GI losses. Vomiting and diarrhea, worldwide, of course, is much higher. Third spacing, which includes burns and pancreatitis, would be another cause for it. Under these circumstances, you'll find that the urinary sodium for the renal ones, because your kidneys aren't functioning normally, is high. Because you'd think if you're hyponatremic, we're trying to hold the sodium back. But if your kidneys aren't functioning, that's why it's high. But the extrarenal causes, your kidneys are functioning okay, so they can hold back the sodium, so not much sodium is pumped to the urine. Euvolemic hyponatremia. Well, we're going to talk a bit more about that, because at the end of this, I'm going to share an osmosis.org video on SIADH, which goes through the whole thing. So in euvolemic hyponatremia, you do have an increase in your extracellular volume and you have lost a bit of sodium in the urine. So overall, you have a mild ESF expansion with total body sodium is about normal, slightly lower. SIADH is both exogenous and endogenous, and we'll see more about that in the video. The underlying thing is that you're hypoosmolar and you're hyponatremic in your blood, and yet your body's still making antidiuretic hormone. I mean, you need to diurese it out. You think, oh, I'm hypoosmotic, I need to diurese it out. But you're creating an antidiuretic hormone. So that's sort of opposing the whole thing. Okay, and the urine is therefore relatively concentrated. And there's some of the numbers. We'll go through rapidly that. There's in the video, I'll tell you more about small cell tumors as a cause of the bronchogenic tumors of it, and about other causes of SIADH and the types. The last group we're going to look at is the hypervolemic. Remember, we had the apparent, hypovolemic, euvolemic, SIADH, and hypervolemic. Hypervolemic, you've got more sodium, but you've got more water than sodium, so you're waterlogged, and your overall sodium is elevated, but you're still hyponatremic when you measure it. The way I remember this is think of a major organ system and make it stuffed. So your heart, CCF, your kidneys, renal failure, chronic renal failure, your liver failure, all of those will cause hypovolemic hyponatremic. Renal failure, in that case, unsurprisingly, the urinary sodium will actually be greater than 20. Whereas when your kidneys are functioning okay, in cirrhosis and CCF, your urine sodium is lower. That's one way to figure it out. And water intoxication, this sort of patient would fall into that, where the volume status, she's over full of water and she's hyponatremic. Essentially, it's water restriction, or in her case, you're having to give some 3% saline. But generally, it's water. Okay, so we've looked at a case that showed water intoxication, a hypovolemic hyponatremia cause. We've then seen the way that they've used 3% saline, the way you can get seizures, and that you can have apparent, or you can have hyponatremic, hypovolemic, euvolemic, and hypervolemic hyponatremia. A few things, these are just a couple of bits to add at the end. Most people, when you've got a sodium less than 110, will use 3% saline, or if you have a gross decreased level of consciousness, or if you've had a seizure, most people would give normal 3% saline. How much do you give? Most people will give, most of the time, I would give 100 mils and then reassess it in a couple of hours. 100 mils over an hour. You can actually work out what the sodium deficit is, and therefore how much 3% saline you'll have to do to bring it back up to normal. But that's going to be over a longer period of time. The reality is you give some, reassess where you're up to. Those symptoms of hyponatremia, a lot of it's to do with cerebral edema. So with this lady, that confusion, the ataxia was all to do with cerebral edema. Okay. That's all I'm going to do for the PowerPoint presentation. I'm just now going to share the SIADH video from osmosis.org, and make sure you've got the sound. And put that on, and we'll just listen through it together. It's very good. It's quite complete. We'll learn a few things about the whole thing. So let's see how it goes.
The antidiuretic hormone, abbreviated as ADH, is the hormone that controls water retention in the body. It also constricts blood vessels, and incidentally, the vasoconstrictor drug called vasopressin is just ADH. So anyways, the more ADH floating around in your blood, the more fluid you retain. The less ADH in your blood, the more fluid you excrete. Now, the nephrons in your kidneys are the structures that physically control how much water is excreted from your body. Nephrons are mostly a series of tubes attached end to end that move fluids and wastes toward the bladder. These tubes, though, also allow fluids and electrolytes to move through the tube walls and back into the blood if needed. ADH affects the last two-thirds of these tubes, called the distal convoluted tubule and the collecting ducts. These tubes focus almost exclusively on reabsorbing water back into the blood, and the walls of these tubes are unsurprisingly made up of cells, which is a common trait among living things, but these cells have proteins called aquaporins, and aquaporins allow water to move quickly in and out of cells. The more ADH floating around in the blood, the more aquaporins are available to facilitate water movement through the cell. So when ADH is low, most of the water flows through the distal convoluted tubule and the collecting duct, giving us diluted urine. When ADH is high, on the other hand, aquaporins grab much of the water passing through these tubes and throws them back into the blood. Now when I drink a glass of water and that water is absorbed into my blood, my plasma osmolality drops, which means I'm diluting my blood with that water. And that means that there's more fluid for all those blood cells to bounce around in. The part of my brain called the hypothalamus sees this drop in plasma osmolality and tells the pituitary gland to slow down the release of ADH. Low ADH leads to lots of diluted urine, which brings our plasma osmolality back to normal, and that is a nifty feedback loop. Now suppose ADH continues to be released even though my plasma osmolality has dropped. We're going to continue retaining water, and as we drink more and more water, we might expect our plasma osmolality to continue dropping. However, this isn't really actually what happens. As more water is retained, it dilutes the other solutes floating around in our blood, like sodium. The extra fluid also takes up more space in our blood vessels. And this taking up of more space issue triggers another mechanism in our body that causes the hormone aldosterone to stop being released. Less aldosterone floating around in the blood causes the body to start dumping sodium from the blood into the urine. Concentration gradients cause water to follow sodium, so we end up with excess water being excreted in the urine with the sodium, which normalizes the fluid volume in the blood. So now our body is removing sodium from the blood that already has a low concentration of sodium. Uh-oh. This means that plasma sodium osmolarity is dropping significantly. And this whole fiasco we just talked about is called syndrome of inappropriate antidiuretic hormone, or sometimes just shortened to SIADH. There are 4 patterns of ADH release in people with SIADH. Type A is completely erratic and is independent of the plasma osmolality. ADH levels tend to be very high, so the maximum amount of fluid is retained, causing urine osmolality to be very high as well. Type B is a constant release of a moderate amount of ADH. Type C is the baseline plasma sodium concentration level is set lower than normal. It's like you turn down the thermostat in your house to a new lower level. This type is particularly unique because the plasma sodium concentration is stable, unlike other SIADHs where it would continue to fall. And type D is the least common type of SIADH where ADH secretion is completely normal, yet urine osmolality is still high. The symptoms a person with SIADH experiences is caused by the dilution and loss of sodium in the blood. When your body has a lower sodium concentration than normal, you experience symptoms similar to dehydration or any other condition where sodium is low. Symptoms like headaches, nausea, and vomiting are common initially, along with muscle cramps and tremors. As the sodium concentration continues to get lower in your blood, though, the neurons in your brain begin to swell, leading to cerebral edema. This causes symptoms like confusion, mood swings, and hallucinations. And if left untreated, it can lead to the common downward trends that we see in most illnesses, like seizure, coma, and death. It's not hard to suspect someone might have SIADH. All we have to do is consider your symptoms in addition to your lab results. Low blood sodium levels and low plasma osmolarity combined with high urine osmolality and high urine sodium is a big giant red flag for SIADH. So what causes SIADH? Pretty much anything that messes with the secretion of ADH. Conditions like strokes, hemorrhages, or trauma to the brain can mess up the brain's ability to release ADH. Similarly, some drugs that act on the brain like mood stabilizers or anti-epileptics can change the way ADH is released. Surgery in general often causes an increased secretion of ADH, though we're not really entirely sure why. Obviously, brain surgery, specifically to the pituitary gland, also might cause extra ADH to be released. ADH can also be produced ectopically by tumors, which means the tumors themselves produce ADH outside of the pituitary gland and release ADH into the bloodstream. Small cell carcinoma in the lungs is the type of cancer most likely to release ADH in this way. Infections in the lungs and brain are also linked to an increased risk of ADH secretion. If some of your family members have had SIADH before, that means that there's a possibility you may develop it as well. The best treatment for SIADH is to figure out what the underlying cause of the excessive ADH is, and then treat that problem. Otherwise, we can manage SIADH by restricting your daily intake of fluid. You can also start a high salt and high protein diet to help replace the excess loss of sodium. Drugs that inhibit ADH secretion can also be used in chronic SIADH situations. For people who have really severe acute hyponatremia symptoms, hypertonic IV fluids are usually administered.
Well, thank you very much. Thanks to osmosis.org, and thanks for listening to this summary of hyponatremia, and specifically in this case water intoxication, and a review of SIADH. Stay with me next time and we'll go through yet another electrolyte on a PowerPoint presentation with some discussion. Thanks for today, and I'll catch you next time. Cheers.